screen
Yes,
with?
please. Yes, please.
Okay, so this was a little unusual foreign body I came across. So this was a young male who was finger counting in the right eye after a corneal tear he presented to us. So you can see a entry wound over here and dense vitreous hemorrhage. There was no view of fundus. The long foreign body, which was like standing like a peg missile in the posterior segment, and it was reaching almost up to the posterior lens capsule. The lens was absolutely clear, and on CT scan we could see that there was a posterior perforation as well. So this is on the table. You can see the anterior end of the foreign body is almost visible behind the lens. So did a 25 gauge vitrectomy for this patient. So after clearing the vitreous hemorrhage, we can see that there is a foreign body which is there. So I usually make a separate retinotomy for sclerostomy for removing the foreign body. So just held this with a forceps and it came out very easily, aligned it and took it out. So it's a really long foreign body and the challenge was to preserve the lens. So it was around 15 millimeter long. Now the next challenge was to uh, contain the perforation. Now, once I went back, did the PVD, I did air fluid exchange under a very low air pressure, say around 15, and then just laser at the retinotomy site. When I came out, I could see the subconjunctival air, but I did nothing, just close the ports and put 25% SF6 gas. Uh, so I'm sorry. So this is how it looks like in the post-operative period. The patient gained 6/6 vision. The lens was clear. And if you see, this was the side where it was embedded and it had nicely scarred up. So this patient, in fact, did develop nuclear cataract almost 1.5 years after the surgery and underwent cataract surgery for the same, and the patient remained 6/6. So this is just a short presentation how I diffused a torpedo.
Excellent.
Wonderful, wonderful
Excellent.
result here.
Very
Wonderful,
nice.
very
Very
nice.
nice. Sunir, any thoughts?
It was similar to
Yeah.
the IOF case. It's great that your patient did so beautifully with just a gas tamponade. And I think these cases where it doesn't violate the lens capsule, as much as obviously our goal is to remove the IOFB and keep the retina flat, it's nice when you can keep the natural lens in place. And so beautiful
Yeah.
job.
But do you believe that anybody would actually try going behind all the way and trying to stitch it from behind the exit one?
I think at that point, I think in this case, it's really posterior and you can do it, but there's a trade-off between you're trying to close the hole and rotating the eye that much. There's going to be pressure on the globe. And so I think going back that far to close it was maybe an unnecessary step.
Because I'm just thinking that, okay, that means Vinod could manage it with the gas, but what if we end up using oil? And what are you going to deal with the oil with? So that is the next round of challenge.
In
No,
fact, that is the reason why I did not want to
Yeah,
put the oil.
yeah, I agree with
exactly.
Vinod,
Dr. Bender?
because going in a oil, and if he goes in a sub in orbital space and post retrovolvulus abscess, it's a messy affair. But generally, what you have even 4 or 5 days of time, you have a fibrosis around the exit wound. And if you are careful enough, what the point he has rightly mentioned, he like around 15 pressure, low pressure he was working on. So he did not exert any pressure. So what happened? Probably that remains sealed. Even though foreign body come up, but we have a fibrosis around it. Just maybe gas partly would have leaked. But I think that holds an, I think, extremely well handled case, I would say. Most of the time is not necessary. Maybe I had an opportunity to suture once. I tried externally going foreign, but what happened when the wound is leaking? Sometimes you try to rotate the globe around, globe keeps on collapsing, your anatomy is distorted, visibility is compromised. There is a case, eventually we suture that from inside, took the suture inside. That was a heroic effort. Sometimes there are reports putting your spine, just scleral piece, going inside and plugging in that, or sort of things people have tried. And now amniotic membrane, somebody is trying that. Yeah, there are options, various, but most of the time, if you give 4 or 5 days, if you're doing immediately after injury, yes, the wound is open. Then you are land up in a problem. But if you already have a 3-4 days are gone, and if you are careful enough and see that you are not distorting globe during surgery, I think you can hold on well.
Great, great.
You know,
Anybody else has any quick
yeah,
comment?
yeah, Vinod, I think, I don't know if you can put up your slide again. I was extremely interested in your OCT post-operatively to look at the sclera, because what Dr. Pramod Bende also mentioned, that there can be post-operative scar or fibrosis at the exit site. But looking at this sclera, I don't know if you could see all the scans. It didn't look like there was any perforation posteriorly, but it would be good to know, how soon it causes scarring. And it doesn't mean that during the surgery in a fresh wound it would be closed. It may still be open, and especially if you put oil, it's likely to go into the retrobulbar space and then come anteriorly. I think
Further, you
overall
may
it was
not be
a good-
lucky every time. No, you may not be lucky every time. You see,
Yeah.
if it's a large wound, something maybe requires something. What Pramod was saying, amniotic membrane or something.
Yeah.
There's
You,
some
you have to
glowing.
be prepared for everything. You never know where you are going to land up. You have to be prepared for everything.